Some of the surviving preterm babies may have neurodevelopmental disabilities in the form of cerebral palsy, cognition problems, visual, hearing and behavior related problems. Intact outcomes, that is survival without disability, requires screening these at risk preterms to detect early deviations from normal development and employ timely interventions. We as pediatricians have the responsibility to continue care of babies who are born preterm and discharge after special care in NICU. In this webinar, we will learn all about the care of preterm babies after discharge from NICU. Discharge planning, what to include in discharge summary and checklist used before discharge. Medical care, monitoring of growth, nutrition advice and immunization of preterm baby. Neurodevelopmental assessment, recommendations on screening tests and the suggested schedules for the multi-domain developmental screening tests. Continuity of care from NICU to home requires discharge planning. Each unit should have a place dedicated to follow-up services that includes all or most of the services under one roof. Dedicated personnel must coordinate the screening of at-risk babies. The unit may plan one or more days of the week dedicated to follow-up. The preterm baby's family must be given a discharge summary that includes all the risk factors from antenatal period and after birth that may risk development of a preterm baby. Example, antenatal steroids, need for resuscitation at birth, need for oxygen or ventilation. This will ensure continuity of care after discharge from NICU. Having a checklist will ensure patient safety and improve quality of discharge process. A model checklist from our hospital is displayed. The objectives of care can be clubbed under the heads of medical care and neurodevelopmental assessment. As pediatricians, we often are familiar with the medical care of neonates, but there are some special issues specific to preterm babies. Preterm babies take little longer, about 2 weeks more than the term babies to regain the birth weight. After that, they must gain about 15 to 20 grams every day. Head growth may be a little faster, 0.5 to 1 centimeters per week than in term babies in the first few weeks of life. Baby's weight, length and OFC must be plotted on growth charts for preterm babies weekly in the first few weeks of life. Fenton's growth chart, specially designed for preterm babies, is a favored preterm growth chart. Tracking of weight and OFC on the growth charts is more informative than the numbers we see. Fenton's growth chart allows plotting till 50 weeks of postmenstrual age. One can then change to WHO growth charts thereafter. Preterm babies must be fed breast milk alone till 6 months of age, and complementary feeding may be started after that, like in term born units. Preterm babies are at higher risk of infections and timely immunization is even more important. There is no change in the schedule of immunization from term born babies. The babies must be vaccinated as per their chronological age. Studies on preterm babies showed that the protective levels of immune response were demonstrated after standard doses and schedules of vaccines. BCG and OPV can be given on or after 34 weeks gestation once the baby is medically stable and ready to go home. Hepatitis B may be given after 30 days or at discharge if the mother is negative or protected. Besides medical care, preterm babies must be screened at the right time by the right method for neurodevelopmental assessment. The success of a follow-up program depends on the parents' knowledge of the need for screening, the benefits of timely intervention. They must be educated at regular intervals while the baby is still in NICU and even after, on the need for such testing, schedules for follow-up and anticipated interventions. Example, laser photocoagulation, hearing aid, etc. ROP screening must be completed as discussed and vision assessed at 9 to 12 months for refraction and squint. Hearing screen and diagnostic testing must be completed before baby is 6 months old. Developmental assessment must be done periodically, suggested at 4, 8 and 12 months. A neurosonogram should be done at 1 to 2 weeks of life and repeated at 36 to 40 weeks post-menstrual age. Baby may be referred to a specialist, a neurologist, orthopedician or physical medicine department and need interventions if there is a deviation in development that is found. The families must be educated on the need to follow up till the ophthalmologist informs the screening is complete or treatment for ROP is required. In addition to ROP checks, preterm babies must be examined by the eye specialist at 9 to 12 months of age for refraction, squint and other visual problems. They are at high risk of myopia, strabismus and late retinal detachment and many other eye problems. Preterm sick babies are at increased risk of sensory neural hearing loss. The universal screening program for hearing that uses OAE will miss this type of hearing loss. Hence, preterm babies must have an AABR automated BERA screen before discharge from the hospital. An abnormal hearing screen must be followed by diagnostic evaluation and a decision to intervene must be made before the baby is 6 months old. Delay in treatment can adversely affect the language development of the baby. Neurodevelopmental assessment includes assessment of tone and motor milestones to detect cerebral palsy early. Multi-domain developmental tests must evaluate cognition, vision, hearing and language as well. Some of these tools are CDC grade, Denver 2 and Bailey scale of development. Periodic checks at 4, 8 and 12 months of age corrected for prematurity are suggested. At each visit, baby may be initiated on interventions if a deviation in development is noted. Appropriate follow-up is an opportunity to detect early and correct deviations in development. This will minimize disability in preterm survivors. The neonatologist must remain the nodal person of follow-up service to explain to the family the findings of screening tests and treatments planned for disabilities. Coordination of the specialist visits may be facilitated by dedicated staff. They are involved in parent education from the beginning, managing appointments and guiding parents to intervention programs. The goal of saving preterm babies intact, that is without disability, can be achieved by timely screening as discussed and appropriate interventions. In the 2 slides that follow, we show the developmental follow-up in a table. In the table, we see columns showing the timing of suggested test. It is also suggested what may be done if there is a deviation from developmental assessment being normal.